When you attend RSNA 2023, our industry influencers and radiology trailblazers are set to help you embrace what's next in medical imaging. Imagine what new medical imaging practices and technology can teach you about collaboration and innovation. We have everything you need, all in one place, as we help you explore how to lead through change. Join us November 26th through the 30th for the biggest week in radiology, in person, virtually, or both. Early bird pricing is available through October 4th. Register now for RSNA 2023 at rsna.org/register. Hi, my name is Elliott Kirk Gozansky from New York University Langone Health and Grossman School of Medicine. Welcome to the RSNA RadioGraphics podcast. I will be talking about chest CT angiography for acute aortic pathologic conditions, pearls and pitfalls, by Jane Coe, Jonathan Goldstein, Larry Latson, Leah Azor, myself, Elliott Gozansky, William Moore, Smita Patel, and Barry Hutchinson. Any discussion of the aorta should start with a review of the histology, as its understanding is critical to the understanding of the aortic pathology. Fortunately, the level of detail that we need is fairly straightforward. The aortic wall can be thought of three primary layers: the intima, which is normally 1 to 3 cell layers thick and includes the endothelium. This is the histologic location of atherosclerotic plaque and calcification. The media, the middle layer, which is thick and predominantly made up of smooth muscle. Adventitia, the outermost layer, is predominantly strong connective tissue. From a radiologist standpoint, it is important to understand how a dissection is correctly typed. Using the Stanford classification, there has been a disconnect between what some anatomists teach as a type A and what surgeons consider a type A, the latter of which is arguably more important when it comes to clinical practice. For a surgeon following the Stanford classification, a type A dissection would be one that involves the aortic root or ascending aorta. If those two structures are not involved, it is a type B. New surgical guidelines set forth in 2020 extend the type A to include the portion of the aorta that gives rise to the nominate artery, with dependence on the site of the entry tear. Those details aside, the manuscript discusses many of the logistics surrounding CTA acquisition, starting with the acquisition of a non-contrast, which can be helpful in troubleshooting post-surgical changes and determining the relative acuity of an intramural hematoma, as they tend to be more dense in the acute phase and gradually become hypodense in more chronic phase. The clinical presentation, however, typically takes precedence over the radiologic chronicity. Discussed next in the manuscript are details surrounding the acquisition of the contrast-enhanced CT angiogram. Depending on the setting and the available equipment, the study may be acquired without EKG gating, resulting in overall study time savings, but at the risk of a non-diagnostic evaluation of the aortic root and ascending aorta. High pitch mode, if available, can ameliorate the lack of gating, particularly when time is of the essence. Various scan triggering methods are reviewed, including bolus tracking and timing bolus techniques. Other acquisition parameters are discussed, including contrast type, volume, rate, as well as tube potential and current. On most CT scanners, dual energy acquisition is not utilized for acute aortic syndromes, as the virtual non-contrast images may be degraded by pulsation artifacts that mimic intramural hematoma. EKG gating may provide a solution, however many scanners do not offer dual energy acquisition in combination with EKG gating. This is a good segue into the discussion of EKG gating, where the manuscript carries on to enumerate the pros and cons of the two primary gating techniques of prospective gating versus retrospective gating. During prospective gating, the system is only acquiring data during a specific phase or phases of the cardiac cycle. Since the density matrix only requires 180 degrees of exposure to produce the image, there is a significant radiation dose savings by this technique. However, it uses axial acquisition, which takes more time and is more prone to artifact associated with patient motion or irregular heart rate. Retrospective gating is a low-pitch helical acquisition that acquires data over the entire cardiac cycle and then parses the information into various phases after the acquisition. It results in significantly higher radiation doses, but tends to be less negatively impacted by patient motion. Moving on to a discussion of the acute aortic diseases, acute aortic syndrome has traditionally been divided into the classic aortic dissection, intramural hematoma, and penetrating atherosclerotic ulcer. More recently, we have added limited intimal tear or limited dissection, both of those are the same entity, onto the list, as well as iatrogenic dissections. The manuscript carries on with a discussion of the classification of aortic dissections, including the Stanford and DeBakey classification systems. In all of the places that I have practiced, everyone seems to gravitate towards the Stanford criteria, where type A dissection involves the aortic root or ascending aorta. All other dissections are considered to be type B. When considering the classic dissection, it is often the case that the dissection flap, as it passes by a branch artery, merely pops off that branch artery. Other times, the aortic dissection can actually extend into the branch artery, and on occasion, it can cause thrombosis of that branch vessel. But one of the things to keep in mind, if the dissection flap pops off the vessel, is that the natural fenestration that's left behind within that dissection flap doesn't necessarily line up with that branch artery at the site of the dissection. As a result, there can be dynamic obstruction of that branch artery as the systolic wave comes through the false lumen, pushing the dissection flap over and covering that branch artery. That is one of the advantages of having retrospective gating, because you can actually directly observe the dynamic obstruction. I should go on to point out that the dynamic obstruction can result in end organ ischemia. Next, penetrating atherosclerotic is discussed, and I find that to be one of the more difficult diagnoses to make, in part because there's a lot of overlap between the penetrating atherosclerotic ulcer and an ulcerative plaque. The only distinction is a histologic distinction, and it is a matter of whether or not the intima has been violated or not. And that can be very difficult to tell. As mentioned earlier, the intima is only 1 to 3 cell layers thick, so in and of itself, we can't delineate it in a CT. If there are atherosclerotic calcifications within the intima, right, that's the location of the intimal calcifications, and they're broken, then we can use that as a guide to let us know that this little pool of contrast is in fact a penetrating atherosclerotic ulcer. Otherwise, I think a lot of the time we have to give it as a differential, that it's either a penetrating atherosclerotic ulcer or it's an ulcerative plaque. Most of the patients that I have seen with penetrating atherosclerotic ulcers, they tend to be much more indolent. So we watch them. They don't seem to have as bad a prognosis as the other members of the acute aortic syndrome. I think that is unless they're associated with an intramural hematoma. So the penetrating atherosclerotic ulcer can be associated with intramural hematoma, and then I think it warrants a more diligent observation. Another important parameter to watch with penetrating atherosclerotic ulcer has to do with the depth of the ulcer. So if the depth is 10 millimeters or greater, or the diameter is 20 millimeters or greater, that has a higher risk of progression. So both of those scenarios warrant more careful follow-up. Discussed next is acute intramural hematoma. It's considered a contained hemorrhage within the aortic media. One of the mechanisms put forth to describe its origin is rupture of the vasa vasorum. However, it can also result from thrombosis of a classic aortic dissection lumen, where a microscopic tear was the entry tear that then closes or is just not identifiable. Intramural hematoma can be a result of trauma or a penetrating atherosclerotic ulcer, as mentioned before. Non-contrast imaging can be helpful in identifying intramural hematoma, as it often appears as a smoothly crescentic, hyperdense lesion within the wall of the aorta, especially in the acute phase. As it becomes subacute, it will become isodense and hypodense when it is in its more chronic phase. On contrast, you can detect an intramural hematoma by abnormal wall thickening, also usually crescentic. And that is an important skill, I think, for everyone to develop, as there is always a risk of someone presenting with an intramural hematoma and end up getting a PE study instead of an aortic study. And the PE studies typically do not have an accompanying non-contrast evaluation. Although not typically included in the acute aortic syndromes, aneurysm rupture is briefly discussed next in the manuscript, including the signs of impending rupture, including periaortic stranding, draping of the aorta, crescentic high attenuation in the aortic wall, and displacement of the intimal calcifications. When rupture does occur, you can see soft tissue stranding and collections within the mediastinum. You can have hemopericardium, hemomediastinum, or hemothorax. The manuscript follows with a discussion of penetrating atherosclerotic ulcer, ulcer-like projections, and intramural blood pool, which we'll discuss in turn. So the penetrating atherosclerotic ulcer we actually have discussed already, and there's a nice figure where it talks about the intimal calcifications and how that can be used as a guide for letting you know when the penetrating atherosclerotic ulcer has extended beyond the intimal layer. If a patient has an intramural hematoma, you can see an outpouching of contrast, mural thrombus, and it is called an ulcer-like projection. If the ulcer-like projection is present in the acute phase, they tend to portend a worse prognosis than if you see an ulcer-like projection in the more chronic phase, like one of the follow-up scans. Intramural blood pool, this is, I think, an interesting entity. It takes place where the aortic dissection has popped off a side branch artery, as we discussed earlier, and there is still sufficient flow from that natural fenestration within the dissection flap through the mostly thrombosed intramural hematoma and out into the branch artery. There can be a pool of blood within the intramural hematoma, and that's where you come up with this intramural blood pool. Sometimes you'll see it just as a channel. The presence or absence of an intramural blood pool doesn't really modify the patient's prognosis, although I will say in the absence of blood flow from the true lumen to the branch artery, there is, I think, a theoretically increased risk of ischemia to whatever that vessel was supplying. However, I think in a lot of the cases, there is collateral supply. Next in the manuscript is dealing with some of the pitfalls of evaluating wall thickening, including mural thrombus, tumor, and vasculitis. Mural thrombus, I think we see frequently in patients with acute aortic syndrome, as it is often associated with atheroma. One finding that can help differentiate mural thrombus from intramural hematoma is laterally located intimal calcifications. If the hypodense material is sitting on top of normally positioned or laterally located intimal calcifications, that helps build confidence that what you're seeing is on top of the aortic wall instead of within the aortic wall. Also, as you're scrolling through in an axial view, mural thrombus tends to have an undulating contour, whereas intramural hematoma is much more typically smoothly contoured and crescentic. The next mimic that I want to discuss is vasculitis. Often, the vasculitis patient presents to you differently than the aortic dissection patient. So a vasculitis patient will often come to you from the rheumatologist. They'll have chronic, more indolent chest pain as opposed to the tearing chest pain that's classically associated with an aortic dissection or an intramural hematoma. When you're scrolling through a vasculitis case, the aortic thickening tends to be circumferential as opposed to the lenticular or crescentic shape that you typically see in an intramural hematoma. As you're scrolling through the aorta in a vasculitis patient, you'll see that the wall thickening will come and go as you scroll through. You'll have parts of the aorta where there's more thickening, and then parts of the aorta that are more normal. Whereas in an intramural hematoma, there typically isn't waxing and waning of aortic involvement. Finally, in this section is the angiosarcoma of the thoracic aorta, which is a rare entity. This diagnosis should be entertained when you see a large intravascular filling defect with a lobulated morphology, particularly in the absence of aortic atherosclerotic disease or aortic dilatation. Next, we come to limited intimal tear, also known as limited dissection. These are most often seen in the ascending aorta and are occasionally confused with a penetrating atherosclerotic ulcer. What can help you differentiate these two entities is the presence or absence of atherosclerotic disease. That is, a limited intimal tear is not associated with the presence of atherosclerotic disease, whereas a penetrating atherosclerotic ulcer is associated with atherosclerotic disease. I think correct diagnosis of these entities is important because, as mentioned earlier, the penetrating atherosclerotic ulcer tends to be much more indolent, whereas the limited intimal tear behaves like a type A dissection and warrants surgical repair. Circumferential aortic dissections are discussed next, and this is a rare entity that occurs radially rather than longitudinally, and are often located near the origins of the coronary arteries originating in the aortic root and proximal ascending aorta. In this entity, the intimomedial flaps separate and move antegrade with blood flow. This can result in dynamic obstruction of the arch vessels. Alternatively, they can flow retrogradely and result in severe aortic regurgitation, or left ventricular outflow tract obstruction. The last section of the manuscript discusses the post-surgical aorta, and in particular, it discusses the two different surgical techniques for repairing the aorta, in particular the ascending aorta. The most common used today is the interposition graft technique, where the diseased aorta is resected and the aortic graft is sewn in place, usually involving the ascending aorta and frequently a portion of the proximal aortic arch called hemiarch replacement. An older technique that is rarely used these days, but you could see this in follow-up, is called the inclusion graft technique. In this case, the diseased aorta is opened up and aortic graft is sewn inside the diseased aorta, and then the diseased aorta is closed around the graft. Originally, this was thought to help protect the graft from host response or infection, but it turned out not to be that helpful, so this technique has fallen out of favor. Different devices utilized during surgery are also discussed, such as pledgets, and those can be important because they are often radio-opaque. One of the important acquisitions to obtain in the post-surgical state is a non-contrast study. That way you can compare what is radiodense from the surgery itself and differentiate that from the possibility of having a stitch pseudoaneurysm or leak in the post-surgical patient. Discussed here are some of the highlights from the manuscript entitled Chest CT Angiography for Acute Aortic Pathologic Conditions, Pearls and Pitfalls. Thank you.